All right. Good morning. I think the people are still slowly. All right. Good morning, everyone. I think we're going to get started since we have 45 minutes. Is that right? Okay. Great. I think some familiar faces, some new faces. That's fantastic. My name is Satish Chonat. I'm a pediatrician, actually, but I do see young adults as well. So that's great because I think we like that crossover. And then we have a few of my colleagues sitting at the back as well. So feel free to jump in. So this is going to be purely not just me kind of having some slides. This is purely for discussion. And we've always had great discussions here, and especially in the congenital TTP section, I think. So I'm looking forward to it. So the topic that Claire gave me was to discuss some of the modern approaches. So not necessarily any new treatments per se, but what are we thinking in terms of going forward, managing patients with congenital TTP? Okay. So I have a lab. So I take care of mice with a variety of diseases, especially I do a lot of work with sickle cell disease as well. So some of these is actually supporting my research in the lab. Is anyone who does not know what is congenital TTP? I mean, I thought, there could be some people who may be new, and I want to make sure that I can actually reach everyone, the audience about it. But so you all know Adam TS13. It's always sometimes as a refresher. And I actually use the slides when I explain to my patients or parents or guardians and families, etc. So that's like a scissor, which we expect to chop up that really sticky protein. If you don't chop up, it's called VWF or von Willebrand factor. It's really an important protein for us to make sure we don't bleed easily. So typically, what happens is that those red sticky substance called VWF binds to platelets. Those gray things are platelets, and as it keeps binding, that's a normal job. That MTS13 kind of chops it up, and you have small pieces. Okay, and this is in a so-called healthy state, so you don't have any issues. What happens in TTP, as you can imagine, there is lack of ADAMTS13. So in congenital TTP, there's a genetic deficiency. In immune TTP, I think it's downstairs, they're antibodies, so they are proteins which kind of bind attached to that ADAMTS13 and make sure it does not do its job properly. So they actually make it, but then it's not effective. In congenital TTP, there's genetic deficiency, so there's complete absence. So as you can see, there's lack of it. So there's what we call as microthrombi, or small little blood clots that can happen in many important blood vessels, especially brain, kidneys, etc., that we most worry about. And the thought is that as the red blood cells kind of pass through that micro blood clots, it kind of gets broken up. And that's what people call it as, you might have heard MAHA, MAHA, or microangiopathic hemolytic anemia. So those little broken down red blood cells are called schistocytes. And that's where we look for under the microscope. And that's really kind of a part of a diagnosis. So we want hematologists to go look under the blood smear. So there's a challenge, right? Because you expect the blood machine to pick up these and be able to report it for physicians who are not comfortable looking under the microscope, such as emergency physician doctors, and they don't have time. So as you can imagine, these little microclots happening on multiple different parts of the body can lead to organ injury, right? Because there's not enough blood flow. Because red blood cells carries oxygen around, so there's not enough oxygen going around. There's lack of supply of a variety of things, so there's organ injury. So I want to kind of highlight it because we have some newcomers, you have patients who take care of really young children, then we have adults. So this is a really good environment for what we want is that we all to kind of talk to each other, help educate each other, or to know what to expect. So, you expect in two different groups. They have childhood, that's typically soon after birth, up to 10 to 12 years of age. So this information is actually from a really well put together registry based off United Kingdom. So babies or young children tend to have this risk of presentation of TTP. And for some reason, we don't know exactly why, they actually do okay if they don't get diagnosed in the younger age group, or they may actually have symptoms that we're not picking up, right? So the thought is that several congenital TTP patients are still not diagnosed, or rather underdiagnosed. And then there's a huge number of patients that get diagnosed during pregnancy, because pregnancy is an important trigger. in those people. So coming to see what are we thinking going forward, right? So this is again a table from the similar paper and kind of put together from a few of the information, but primarily from United Kingdom. What led? So in England, everyone who has TTP currently are prescribed prophylaxis. Okay, meaning they are on these medications. So these are the symptoms that led for the providers or physicians or nurse practitioners, etc. Why did they start plasma? This is a few years ago. Okay, this is when we had plasma. A quarter of them actually are low platelet count, meaning that the 75% of them don't have low platelets count. And that's a challenge. If you don't have low platelet count, it may not get diagnosed as well. And a quarter of them actually had headache, migraines. And several of my patients come to me complaining of headaches. Younger children, we don't know if they know how to actually tell us if they actually have recurrent headaches. And my 7-year-old and my 4-year-old, if they tell me a headache, I usually make sure they drink enough water and then try to put them to bed because I don't necessarily think that's a big deal. And so that still remains a challenge for us. Then there is um, these symptoms of not feeling great, right? Just that feeling of blah, I don't feel like working, I'm tired, the lethargy. The other big thing we worry about, the reason that they started is stroke. Stroke is obvious symptom. And TIA, that I don't know if people have heard of this, is where you have symptoms of weakness or numbness or tingling, um, but it goes away within like 24-hour period. So by definition, it should go away within 24-hour period. So you may feel odd and then um, things get better the next day. So if you don't think about it, that may be a kind of add on and may causing some problems in the brain and may also lead to stroke. So these are the symptoms that actually that people actually had started this prophylaxis or using the medication to help prevent the problem. So this is where I'm trying to come at. Is this burden is what I'm trying to call. Um, by understanding these symptoms, we think that these are risk for acute episodes. So if someone is having multiple of these episodes, we need to be worried about, are these going to cause some long-term organ damage, right? And feel free to jump in because this is something that I want to learn from you all because this is data what you have told us. And especially in children, I most worry because if this is going on, it's going to affect the schooling, learning, and later on, it's harder to get education, get good jobs. Um, it affects interpersonal relationships, depression. It gets really complicated. It's a really a challenging situation. And we all worry about death. We believe especially stroke and cardiac related deaths. Okay. So has anyone here ever been on plasma or car? Yeah. Good. As in, is anyone here still on plasma? Okay. Yeah. So we have those two things, right? We have prophylaxis, we have demand, and feel free, you don't have to feel like you have to reveal what treatment you're on, your education. So there's absolutely no pressure, but it's just me asking questions so that. So there's a demand and on demand. So on demand is when you actually have those symptoms. You go in, you get that's when symptomatic. You often get some plasma, either 1 or 2 units. If you may feel better, they send you home because plasma has ADAMTS13. So that's really the main thing. Prophylaxis that we're using it all the time, and oftentimes is every 2 weeks, but some patients use every week. Plasma comes with its own side effects, so reactions to plasma, et cetera, et cetera. But what they found was that in spite of people getting prophylaxis every 2 weeks, close to half of them continue to have organ damage. That's telling us that that's not sufficient, right? And I think that's where we are at this point of time. We still don't. We have a new product. We'll talk to the next thing is this recombinant ADAMTS13. Okay, are people on recombinant ADAMTS13? So this is basically a study. I'll be brief. It's a phase 3 study, right? So they're trying to use a large number of patients, multi-site, in different parts of the world, where they're trying to understand both the safety as well as how effective it is. And oftentimes for phase 3, they have to compare it. Sorry about the slide got jumbled up. They have to compare it to a standard of care. So the SOC is standard of care. So it could be plasma, it could be CoAIT. Anyone on CoAIT here in the United States? So CoAIT is a product which has factor 8, which is a clotting protein, VWF concentrate, but has some ADAMTS13 in it. So there are some patients still in the United States actually who receive this every twice a week or weekly. Um, but I think it's kind of going down, especially with recombinant ADAMTS13. So they did this study. What they found was, what I want to kind of pay attention to is those who are on plasmas, those two dark lines here. As you can see here, this is by days. By about 1.7 days is what they called it, is that they had less than 10% of ADAMTS13 activity. But those who received recombinant ADAMTS13, it lasted for about 5.2 days, right? But the current recommendation is if you're on plasma already weekly, you can get, well, meaning we recommend ADAMTS13 every week, or those who are on every 2 weeks, actually the recommendation is continue every 2 weeks. But I'll come to it in terms of what's the idea. So this essentially, this recombinant ADAMTS13 obviously helped us, showing that this is certainly helpful by keeping ADAMTS13 levels slightly higher. And the big question is that sufficient, right? I think I'm sure we all. So I'm going to kind of talk about some questions and then we can discuss this. So is there a threshold? Where should we keep that MTS13 activity, right? That can not only treat symptoms, but also help potentially prevent some of the subacute symptoms. When I say subacute, meaning they're not coming in with stroke or active symptoms, but they may actually have some abdominal pain, some headaches, or migraines and not feeling well. So is there a threshold? And we don't know actually, but we would like to know in terms of where should we keep. The other big question is, are these what we should be more thinking about rather than a blood numbers, right? So having the information from patients telling us what's really bothering them is what we need to start thinking, because these are non-specific symptoms unless you have a stroke or you have a low platelet count. So I'll stop here to see what are people's thoughts in terms of how do they feel being on ADAMTS13. Are these symptoms better, or if they did have these symptoms, are these symptoms better after starting ADAMTS13? Yeah.
In my bladder, and it was huge,
Mm.
and that's what caused me to go from symptomatic treatment with plasma to prophylactic.
Okay. So you're receiving prophylactic plasma.
I am.
Okay.
Right now, every 2 weeks.
Okay. But other than porphyria, you didn't have any symptoms.
None other than the TPI
It's
in
yeah.
my mouth. And that is weird. When I was a child,
Yeah.
the TPI was from my legs down. Now I never get TPI in my legs. It's from my trunk up,
Up.
including my mouth.
Yeah. I mean, it's really interesting, right? Some people may never get diagnosed till they're 70, 80 years of age. Or they may have such symptoms that we don't even know if that can be relatable easily or can be diagnosed easily.
But I was on plasma, and it was like every 2 weeks getting really bad headaches, abdominal pain before and after treatment, like muscle spasms the night after these treatments. So then when I got on Adzenma, my headaches, I actually would tally every day I had a headache, and it was 230 days of headaches every single day. And then this new medication is amazing. I will still get a migraine or a headache, but it'll be like a day before I get my infusion. It's almost like my body knows. And then once I get the infusion, it's so much better. So I feel like I still get those days when your arms are hard to lift, and sometimes I'll get petechiae on my face and stuff. But other than that, I feel like it definitely has improved at least my symptoms. I'll only get them the day before I need it. And then once I get it, it's so much better for like 3 days. So, and I saw my Adams was at 70 the day after an infusion. I went and got blood work done just to test it, and it was really high. So that was awesome and exciting to see.
So I've been getting plasma sometimes as often as twice a week, and it's horrible because it was always this. I don't really have any symptoms outside of episodes, but after plasma, you always feel terrible for about 24 to 48 hours.
Yeah.
You get it twice a week, that means you basically feel terrible all the time.
Yeah.
But with that and the new, with the Adzenma, it's been much better. Now, I had a snafu just a few weeks ago where Aetna, thank you, just decided they weren't going to pay for it. So I went about 5 weeks without it, or it's got a stomach bug, and then ended up in the hospital.
Oh.
Where they gave me plasma. And then when you come out after the plasma, the depression and just feeling tired all the time, headaches, 2 weeks, lasted for 2 weeks. Then I got regular eczema, and it was gone in 24 hours.
Oh, that's interesting,
So
right?
it is really, for me at least, it's super life altering.
Yeah. And you receive eczema every
2 weeks.
Every 2 weeks.
Yeah, as long as it's constant, I've been completely fine.
Yeah.
For a while. And there was once or twice where I would feel like, yeah, I'm not feeling so great, and I would get it within the next day or two. It's gone. So it's very helpful. And so far, with no side effects, where with
Yeah.
prone to allergic reactions.
Yeah, that's an important point. I know there's been some side effects reported, but compared to plasma, it has been shown to be fairly helpful. Do you have something to say?
Yeah, I just wanted to say my my granddaughter, she's 5, but I know when she would get the abysmal, sometimes like immediately after, she would just cough and cough and cough. It would stop after about maybe 20 minutes,
Okay.
and then she'd be okay. So,
And this is after every dose of eczema?
yeah, but as she's gotten a little older, it's gotten better.
Okay.
But when she first started getting it, she would just cough,
Yeah.
cough.
Interesting. Okay. Any other side effects that people have experienced after?
We're just marveling at how much life is better.
Oh.
Getting plasma every
Yeah.
other week to getting eczema, it's just life is just so much better.
Is everyone receiving eczema at home? Yeah. Not for you.
I go to the
Infusion center or something? Okay. It's something.
I like it. I've been going for 8 years. I used to go twice a week for plasma.
Yeah.
So I know everyone there and they like me. So like,
Yeah.
it's
Yeah.
very fun. I like keep going.
There is
They just come in and say, "House, how are you?"
And develop, and I know my brother, like, we develop those relationships with people at the
Yes.
infusion center. So when you sever that because you get it at home, it's kind of weird because you feel lost because you miss those
Yeah.
people.
Yeah, my at-home person, I can treat it like a coffee date. I'll have coffee ready and I'll have snacks. So we'll just talk and do the infusion. It's fun. She's a friend now.
Yeah.
Did anyone actually do self-infusion?
No, but Michael and I actually have the same person.
She couldn't tell us that we were.
She's like, I have another patient. I was like, really? There's not that many of them. So.
Can you do
about
self-infusion?
self-infusion? Tell us about self-infusion.
So again, this is maybe state dependent. I don't know if there's any other thought from the people behind at the back of the room, but it's state dependent, and I think is something that you can certainly bring up with the infusion center and also with the insurance to see if that's allowed, because patients with hemophilia have self-induced for decades, and so why is this different? Obviously, for some of the younger children, people who have difficult veins, you obviously want to have someone coming at home, especially if you're going to be receiving this weekly. But there's something that you can certainly discuss that, bring that up. I don't know if anyone else in the back of the room have any thoughts, experiences. I haven't been lucky at Georgia. Yeah. But I've been talking to a few of my colleagues who have been here. They've managed to be able to convince the local authorities to be able to do self-infusions at home.
So we give ourselves an IV.
Correct.
I
Yeah.
always
So
I don't think I can do myself. I don't think I could.
exactly, yeah.
Do your work.
What'd you say? In your port?
Yeah.
That's a good point actually about port. Yeah, because they do some of our patients do have port access at home. Is that right? Patients and family members, or no? Never. Okay.
In New York, I can't even get it
Yeah.
The only reason I'm still on plasma, I've been trying since I was here last year.
Hmm.
Peter's like, yeah.
You need to talk to them.
Yeah.
He's quite. I know. He's very quietly sitting. I'm so.
With the same insurance company. I have that too. You have that, and I got immediately.
Yeah.
They approved it, but then I have all this approval letters and everything, but then they just stopped paying or receiving.
Yeah.
And they would everybody would call and they'd be, oh yeah, we got it. And then I get another this, but then they just stopped. And of course, that was the week when I got the
Yeah, I had to go like an extra week. I had to go 3 weeks the week that happened. It's like having a couple of weeks ago, like a month or so. Back in June. Yeah,
mine was July.
Yeah.
So I needed 3 weeks.
So this is my next slide about okay that now since most people are on prophylaxis once a week or once every other week. The next big question is, are we going to be able to prevent long-term complications, right? I mean, that's what we're actually looking for. Um, so this from a couple of years ago, actually, there's one more came after that, very similar. So in the blue bars, the patients without stroke and those with stroke. What's telling us that is those. So this data is actually most of them. It's actually a mixed bag of those who are on prophylaxis and not on prophylaxis. They've shown that there's a risk of stroke. It starts right at birth and it continues, right? So the hope is that by starting some of these medications, are we able to prevent some long-term complications, right? And so one, we need to have a good collection of information from patients and family members, et cetera, and that needs to be done broadly around the world. And the big question is, if we can prevent stroke, does it help reduce deaths? And what the next question we need to ask is are these complications preventable by keeping your RMTS13 activity much higher? Like I mentioned earlier, if you remember 2 years ago, we had Dr. Maurice Scully come and give, she came from England to give the talk. So I was talking to her that all their patients with the conventional TTP in England actually are on weekly, unless a patient have actually asked to be on every other week. And I mean, that's what they followed. So it'd be very interesting to, what'd you say? You're on weekly too. Yeah, exactly. Yeah. So some of you are on weekly, some of you every other week. And again, because the idea is that it's about after 5 days or so, your RMTS activity starts to come back down. So every 2 weeks is great, but weekly, obviously, there's a slightly higher chance of keeping RMTS13 higher. So that's certainly where we are at this point of time, because if you look at those who have RMTS13 or more than 70%, are those who have a stroke-free survival, right? And so if you have a low RMTS13 of less than 70%, as you can see, that curve starts to coming down, meaning that your stroke-free survival starts to go down, meaning that there's increased risk of stroke by having RMTS activity lower. So this is essentially where we are at this point of time. Again, many of this information are when people are on plasma, right? We hopefully the next few years we can show more and more information about what's happening when patients are on recombinant RMTS13. So we already asked this question, how often? And so one of the things that we want to do in addition to these treatments, I'll stop here to see if people have any other questions or thoughts on how we should move forward.
I had one question. Talking about 40% of patients still show long-term organ damage. Is that in a specific, is it kidneys, is it brain? I mean, is it more common in a certain organ?
So really great question. I think part of the problem of the data that where it came from was a little bit mixed bag. Because the way they collected the data was based on what parents and patients reported. So some are through registry, the International Hereditary TTP Registry is something we're part of. It's a registry of it's the top one, the International Hereditary TTP Registry. They have about just over 100 patients around the world. So there's actually data collected from them. So it's a combination of brain injury, kidney. There's some data on liver injury. And I can't remember actually if they actually looked at the other organs separately. So it is a combination of this, and it seems to be slightly different to certain people. But again, we're focusing on those big organs such as brain and heart and kidney, which are so what we call as vital organs. Are people aware of this international hereditary TB registry? You've heard of it? Yeah. You're on something? Yeah. It's from Oklahoma that they may give you a call once every 6 months or a year or so. Yeah. What do you say? Yeah. Yes. Dr. George started this, and it's actually, like you mentioned, there's about 19 countries or so. So UK has their own congenital TTP registries, about 75 cases. Japan has few cases. So where we at now is we're really happy to get people on Zinma, but we want to start understanding, are these every 2 weeks is sufficient? Do we need to also consider going every weekly for patients? And I think, how do people feel if your provider tells you to do it every week.
I don't have to drive 6 hours.
Because
Right,
you,
6 hours.
you get your plasma every 2 weeks.
I just drive them right now every 2 weeks. I was getting it most of my time at week when I started the prophylactic. But I get it every 2 now because they found out I had 5 strokes. And they weren't great. So
Yeah.
I shouldn't need to go back there. But I drive 6 hours. And I have to stay overnight because I have so many free mats with my plasma. And I drive myself, my husband passed. So I'm driving myself there, having the infusion. And this last month and the month before, it's now affecting my kidneys internally. Like they're grabbing, it's grabbing them, and it hurts. So now that I'm having a physical reaction to it, I'm trying to push harder to get you guys looking at this.
I'm really sorry, really. Stuck.
It's kind of in the middle of the back, no more crowded. That's what you get for living in, peace.
Yeah. These are real true stories, and people have come here. There's several out there. We don't know the challenges.
Yes.
And I think what we're hoping to do is be able to actually, have you all be the voices to be able to actually impact a bigger group. Right? We're not able to make it today.
My nearest hospital is where they live, which is 3 hours away, or in Burlington, which is 3 hours away. And because of the snow belt being between me and Syracuse, I go to Burlington so I can access it all year long. Because I wouldn't be able to get to Syracuse a lot of the time anyway.
Yeah, they know what you're
I
at.
would love that. And then I would gladly have that every day.
As far as frequency, if it keeps you out of the hospital, I take it every day. You have that chunk of your life taken away. You know, you can have this at home or anything like that, and you keep you out of there.
I had a question about dosage.
Yeah.
So now they're doing it for pregnancy. I know there's not a lot on that. So as you get heavier with pregnancy, and how are they deciding just based off your body weight? Like how do they decide exactly how much you're supposed to get when it's changing?
Yeah, it's a really good question. I think we're currently having a bunch of hematologists and maternal fetal medicine doctors sitting together trying to understand where it is. We actually had a meeting yesterday morning just discussing this. Just to give you a brief idea, again, nothing is concrete. This is purely patient dependent at this point in time. Obviously, we recommend out-of-care surgery during pregnancy, so that's number one. Okay, that's pretty clear. The idea is, and I actually asked Dr. Antoon, who actually does a lot of work with pregnancy, do you want to talk about this? Because I think you're an expert in this rather than me.
So remember this is like new, especially using recombinant active in pregnancy, that they study for non with pregnancy. So the idea is to check the RMC during the pregnancy. The dose is adjusted by weight, so it will be adjusted with the pregnancy gets more advanced, the weight is increasing. And the other thing is we are going to try to check the RMC after the dose to see how long it lasts and to maintain a certain level. So in preparation for the delivery, because by the time of delivery, we will have to have a plan, and the idea is to give a dose before delivery. So we cover during delivery and it's a high risk for prenatal. This is the idea. There is nothing written, but this is what we will do.
Thank you for answering that. Appreciate it.
So would you do a peak and then a 24-hour and a 48-hour and a 72-hour, like a nice PK trial?
Yeah.
And then if probably 4 to 5 days later to check how much the other years are being dropped to have an idea how often you need to go, especially in pregnancy.
This is my last slide. So a few of us are thinking of having a USTMA open a prospective meeting, start collecting data for patients with congenital TTP, children, all ages. How we think is different, and I want to hear from you of how and what you think that is missing that we need to be able to think about as we move forward to near us being able to have a case study, hopefully for everyone, hopefully being receiving at home. Is in addition to understanding the patients, there's some of them like providers, so family members who actually may have one copy of the gene, right? So trying to understand who are those carriers and do they have symptoms? And that's been raised many times, and I'd like to hear from that. The International Hereditary TTP Registry based out of Oklahoma and the world did not collect blood samples. So we wanted to see if you may be willing, if we say that maybe a couple of times a year to be able to actually collect some blood samples so we can understand. Because what we want to see is that we can predict those triggers. Because we know that it's not just the RMTS13, lack of RMTS13, there may be other reasons that you may be having more symptoms. Why is it one person completely different than the other person? Why is it no one has symptoms till the age 70, for example? They might have had symptoms, but not overt symptoms. So try to understand, are there other reasons that some patients behave differently? And why some people have strokes when they're born soon after or soon after birth? And we also want to make sure that this is not just us asking and collecting data, that there's an opportunity for patients and parents to be able to enter the data themselves, because I think there may be some value of actually asking you to enter the data because you know what you're going through. That I think that may be very important for us, and also hopefully to help address during future studies. I think it's important to be able to actually have a patient-driven future studies. So I'll leave it here to see what your thoughts are, if there's interest. If you want to do this part of USTMA, like I said, the entire country, because we have a lot of patients around Eczema, and we want to see how they're doing on Eczema, how they're doing on plasma, or the crossover, how has it changed? Because if we can then go back and tell someone who's newly diagnosed, saying this is what's going on, and we can actually help them understand where we are and what we can potentially offer. So, thoughts, feedback?
Anything that adds value, I'll sign up for it. I do. But on top of the quantitative blood work, you also have to do a qualitative side, because sometimes blood work doesn't always, I mean, I've had normal platelet count.
Yes.
And doctors tell me, well, this can't be TTP because your platelet count's normal.
Yeah.
And I'm like, well, let me show you bruises from my groin to my knees, and we'll have another conversation. So sometimes it doesn't follow what people are expecting it to be. So that's expanding that definition, I think, would be very valuable to the patients.
No, absolutely right, because we want to educate help the patients, but also educate physicians who are not, TTP experts, because that's most of them, right? Because we want them to make sure that they diagnose these
I
patients.
just got excited the first time an ER doctor knew what it was. I was like, you've heard of it. All right, I'm not going to die. I mean, it is like that.
It's still a very rare disease, extremely rare, compared to immune stuff. We think it's 1 per million, but it's probably even more than that.
I'm just thankful for knowing, like, we're like old, we're old, we're old, we're the same age.
Yeah.
And so for so many years, we didn't even know we had TTP. We thought we had ITP with pneumonia, so we thought that for a lot of years. So there's just been so much more interest and progress and things that we've seen, and so this is amazing. Of course, I would be wide open.
Yeah.
Awesome. For me, it's weird because I was never diagnosed as a child, and I had numerous, really, really bad outbreaks. I know just from somebody finally told me what leaky I was. I just thought when I got sick, it was like a fever thing. So I didn't know. I didn't report it to my parents or anything because I just thought when you had a fever, that's what happened to you. So I thought everybody did. So I rebounded. But when I first was diagnosed, which was when I was pregnant, I kept track of all of my, what my hemoglobin, hematocrit, what my LDH was, what my hemoglobin was, what symptoms I had, and what I thought, the trigger obviously every time was pregnancy. But I kept track of all of those for every single solitary thing. And I asked my doctor, and she was like, "Yeah, I don't want to read that." I was like, "Okay, then."
Yeah, this is a good point. I think this is going to help understand that the doctors maybe not, because these are still very rare disease. Many of them finish their entire medical career not having seen a single TB. Whereas for some reason, where we practice, we have several of them. So it's making us your thoughts?
I'm just thinking, I was a midwife and I used to see low platelets in some of my patients.
The
And I
pregnancy.
just thought, oh, it's because of pregnancy.
That's a really important thought. That's probably what they're talking about the next door, about challenges in diagnosis because of the platelet count during pregnancy, because it's probably thought this is normal for pregnancy. Um, yeah.
And even with us, just patients talking to each other, all of us have slightly different presentations.
Yes.
It's not like mine hurts, like I know when my leg pain, when I start getting my kidney pain, I know it's an episode. But I don't get TB until after a while. So, but then other people get TB first, and
Yeah.
so then headaches, all that kind of stuff. So
Yeah.
It's interesting, we're all a little different.
So this few of the disease groups, what they use is they have an online database, because when we talk to you in the clinic setting for 30 minutes or so, there's only so many questions we can ask and discuss and go back. And the hope is that, and I work with a different rare disease base called PNH, where it's a complement disease. And we've created a similar registry that patients actually can go and log in, enter the data themselves. So things such as that, if 5 people complain about it, there's something that's maybe more common than we thought, right? Because we don't think about joint pains, etc., as being a presenting symptom. Wonderful. Yeah. Sorry.
The biometric data,
Yeah.
I think one thing before or after treatment, you just get raw data, like a patient, and then watching.
Right after treatment, that's like the infusion of anti-histamine. Yeah, it's pretty good, really good point. You probably want it to be ideally what's called as trough levels, but also you want to make sure what happens after anti-histamine. Do any of these so-called markers in the blood change after receiving anti-histamine? So ideally, we want both. So we'll have to have a more planning in terms of how do we do this going forward. Again, it's a small number of patients. We want to do it for really long periods of time. So it will require a lot of people working together. But the challenge is that there are few patients around the country, and we were talking about this yesterday. We maybe actually have a few sites in the country so that people go to these sites to be able to participate, and then do the data collection from home. Just because we can't open these sites in like 50 sites in the United States, right? It's going to be really challenging. Yeah. But yes.
So along the same lines that during the clinical trial for the drug,
Yeah.
there was times right after tested, like 3 hours, 6 hours, 9 hours after that. Is there data from the clinical trial that would be helpful to like maybe know all that stuff? Like, you're allowed to, I'm not allowed to say, or.
I think there's some of the clinical data has been published. Some are still being kind of looked into. So if you're part of this trial, typically the trial is completely finished. You can talk to so talk to the person who enrolled you to ask to see if that data is available to that investigator. Sometimes the data that's available to the investigator, then they can actually, but they're probably not, as Dr. Atkins said.
I
It's
don't
like they're
have
reselling.
it. I don't have it available. I know that they publish after the book,
Well,
but
that's.
they don't
Yeah.
even.
Patient level data.
So,
I just didn't know if there were trends that were common.
it was that group, it's published.
So the largest trends, those are the ones that we did publish,
Okay.
like that 5.2
Yeah.
number that you see, that was what we saw on average. Did we see shorter in some people? Yes, some people that have liked it a lot quicker.
Yeah.
So it went all the way down to 4 days, 4.7, and then you saw the patients that went all the way up to 7 days. But that 5.2 was the average and on average.
Are you asking for your data actually?
Oh,
you're
I
asking
just,
for
no, I
everyone.
just wondered if there were trends, and if the 5.2 is what the,
Yeah.
that's just, I wondered.
And also, maybe we could probably get you the actual paper so they can look at those graphs and get trends.
Well,
Yeah.
as long as it's a common spread.
It is. But again, what's reported is kind of the average.
Is there a, maybe those maybe don't, is there going in where you looking at people's starting points and drop levels, like some people may have had 5 or 10%, some people may have been 0?
Yes.
And
That data was collected, and what we were looking to see was what was